Yeah, thankfully it does not. It doesn't matter whether your heart is in a sinus rhythm or whether it's in atrial fibrillation. It doesn't matter whether you're having premature ventricular contractions or atrial premature contractions. And it even doesn't matter whether or not you have an indwelling pacemaker controlling your heart rhythm. All of those factors have been shown to not influence the accuracy of the device, since the inherent frequency-related information is still embedded in those signals and can be extracted using the technology. So it's equally accurate across all those. Bundle branch block, atrial fibrillation, which are common, so common. Yes, I think so. We don't have data exactly describing the patterns of indexes that predict the likelihood of development of arrhythmia, but you're absolutely right. I think the data is there. It's a matter of being extracted in the correct way and presented in the correct way. I think arrhythmia or sudden death prediction is possible using this technology. The diagnosis of other structural problems such as congenital heart disease or cardiomyopathy is possible using this technology, since all of those conditions will ultimately have an influence on the general electrophysiologic integrity of the heart. Yeah, we don't know exactly what kind of signal, but we think we are resolving changes in the electrophysiology at the cellular level. And we need to do more research to pin this down, but it may relate to processes that are so common, such as the ATP generating processes of the cell. There may be abnormalities in cellular components or even in cellular genetics that might predict or correlate with these functional measurements. We don't yet know exactly what the mechanism is because there are a multitude of indexes, and we don't know that a single index is produced by a single process, but that's a very, very fertile area for research.
I see.
Yes, I think so. Again, the ability to resolve a 30% obstruction from a 60% obstruction, we think is possible using this technology, although at this point in time, I don't think the data is strong enough to support its use in clinical practice. Right now, we're using the device as a detector of severe or interventionable stenosis greater than 70%, and otherwise, the severity levels less than 70% are typically treated medically, and we're not looking yet or looking to identify a vulnerable plaque, for example, at 50% obstruction. But we think that there's a possibility we may be able to using this technology. Yeah. In my practice, I think the likelihood of missing a patient who has disease, the likelihood of missing them if the score is below 4, the severity score, is less than 4%. So in that population, I'm very confident taking those people and treating them medically. In the population that has a severity score above 9 or above, that's a population where the high likelihood of having a severe blockage. That population I submit to coronary angiography directly. So the population that has a score between 4 and 8.5 or 4 and 9 is the population that needs potentially more observation. They may benefit from having another type of diagnostic test like a nuclear stress test or a stress echo to help in the decision-making process. But invariably those patients, unless they are severely symptomatic, can be managed medically. And so we try to intensify the medical therapy, reduce as many risk factors as possible, and then watch carefully by repeat testing. Repeat testing of MCG is useful because the score is a dynamic score. it will change if the severity of the ischemia changes. So if you see a patient whose score is 4 and then 6 months later it's 5 and then it keeps going up, that patient has a problem. That's a patient that needs angiography, needs more treatment. Also, a patient who has a higher score, 7 or 8, who is undergoing now better medical therapy, more intensive treatment with beta blockers, etc., can also experience a reduction in the score that is indicative of a stabilization of their underlying ischemia. We think that the process that we're measuring has a lot to do with endothelial function. And as you improve endothelial function, you improve local perfusion. And we think that that's probably one of the mechanisms by which either a reduction in the score can occur, or on the other side, if endothelial function worsens, that the score can go up.
I see.
Yes, yeah, we have. And it will drop precipitously. If you have a patient with a severe obstruction that undergoes stent implantation, or if you have a patient with multivessel disease that undergoes coronary bypass grafting, the score before and the score after the revascularization procedure is markedly different. The score invariably will come down below 4.
2 or 3 hours, or
yeah, within a couple of hours.